Good morning, everyone. Breast cancer is the commonest form of cancer in women, causing about 25 to 32% of the cancer in women. India has been witnessing a spurt in the number of breast cancer cases among women aged between 30 and 50 years old, and the number is only increasing annually. To discuss this very important topic, we are joined by experts from the Apollo Proton Cancer Care Center. We are joined by Dr. Sapna Nangya. She's a senior consultant in radiation oncology, head, neck, and breast cancer at Apollo Proton Cancer Care Center. She's also clinical. She's a clinical and radiation oncologist with close to 30 years of experience in cancer management. She specializes in the application of precise radiation techniques, research, academics, public education, and awareness. Thank you very much for joining us today, Dr. Swapna.
Thank
We're
you
also
for
being
having me.
joined by, yes, thank you. We are also being joined by Dr. Bhawna Sirohi. She's the lead medical oncologist at Apollo Proton Care Center. She's an experienced medical oncologist who has been in the field for over 25 years. She's an international senior consultant who specializes in the treatment of breast and gastrointestinal cancer. She comes with rich experience of having worked in leading oncology centers around the world. Dr. Sapna, let me go to you first. We've examined the facts and figures about breast cancer, and they're quite alarming. The incidence of this form of cancer has been increasing in India. Do you think there is enough awareness about it among women?
So it's very right, Pratibha, that the incidence of breast cancer is increasing amongst Indian women. And the reasons for that are manifold. One is, of course, that we managed to, deal with what were the illnesses earlier, such as the infectious diseases, and therefore people are living longer. And we expect diseases of growing old, of degeneration, to occur more commonly. And then, of course, is the profile of the Indian woman that's changing. So she's likely to be better fed. She's likely to marry later, have fewer children, possibly breastfeed them for lesser period of time. And I'm sure as we go along, we'll discuss why these are associated with a higher risk of developing breast cancer. So that is true that breast cancer is becoming higher. And awareness, I would say, we don't see the kind of terrible, lumps which were breaking through the skin and so on anymore, like we used to see about a couple of decades ago. But yes, we still do see women who have noted a lump and have not accessed, medical help for like 2-3 months after identifying a breast lump. So there, I would say that awareness is lacking. Women need to know that as soon as they see a breast lump, they need to visit a doctor. And the other thing where we need more awareness, there is a lot of work going on, but still we need more awareness, is about the role of screening. Screening, which is basically the examination of normal women who are not symptomatic to pick up breast cancer early.
Correct. Thank you so much. Dr. Bhavna, there's a common belief among women that, only those who are above 50 to 60 years old are susceptible to cancer. So is this correct? And who is at a risk of getting breast cancer?
So good morning, everyone, and thank you, Pratibha. So I think women per se, being a woman is a risk factor for breast cancer. Any woman of any age can develop it, and men can also develop breast cancer. There is a belief and a myth among the physicians as well, amongst doctors, that women in their 20s and 30s are very unlikely to develop breast cancer. And I've had patients where they've come, they're in their 20s, 30s, either after pregnancy or during breastfeeding, where they've been given antibiotics, and some of them have been referred to a psychologist for keeping on coming and seeing the doctor. So in the NHS in UK, where I've spent more than 2 decades, if this was a red flag, if a young person came to the clinic more than 3 times or the 3rd time, they were on an expedited 2-week referral pathway for cancer. Because, somebody who's young has so many other priorities at that time, family, career, and, to get on with life, dating, a lot of things. So you would not want to go and see a doctor. So I would say that, any age is not immune to developing breast cancer. If you have any symptoms or anything that is like a red flag for cancer, you must take advice, and especially if you have a family member who's had any type of cancer, take some advice.
Right. Thank you for that. Dr. Sapna, what are the common symptoms that manifest in women who are likely to have breast cancer?
So the commonest symptom is a lump in the breast. A lump in the breast is never to be disregarded. Cancer is not the only thing that causes a lump, but yes, a lump in the breast is something that should not be disregarded. The other thing that can present, or breast cancer can present us, is a lump in the underarm. So these two are some things which are important. Then nipple-related symptoms. So an ulceration of the nipple, retraction and inversion of the nipple is something that can be a symptom of cancer. Dimpling of the skin. So, I'm sure as we go along, when we discuss self-breast examination, that is one of the things that you look out for. So dimpling of the skin is not to be disregarded. Dimpling or a new ulceration of the skin is not to be disregarded. The other thing that, it's not very common, but often missed, is the presence of erythema, which is redness and swelling of the breast. So there is a particular kind of breast cancer called inflammatory breast cancer, which presents like this, which doesn't feel like a breast lump. It just feels like inflammation. And that is, again, something that should prompt a visit to the doctor.
Right. Are all breast lumps malignant?
No, all breast lumps are not malignant. There are other reasons for having lumps. So there can be benign lumps, benign tumors, such as something that we call a fibroadenoma, which is a fairly common lump amongst young women. Then there's fibroadenosis, which is basically a clustering of the glandular structure of the breast with a little bit of inflammation. Then there's something called mastitis. And then, of course, there are many others. So mastitis is basically an infection of the breast. Very often in pregnant women, there can be a lump that forms, which is because of inflammation of the milk glands. However, one must always remember that in pregnant women, very often cancer is missed because it's mistaken for mastitis. So these are three that I've listed, which are non-cancerous. There are many more reasons for having a breast lump that is actually not cancer. Even fat necrosis, can cause injury leading to fat necrosis, can present as a lump. So these are some of the non-cancerous causes of having a lump in the breast.
Yes. So, Dr. Bhawna, is it possible to detect cancer early on, and how does one do that?
So yes, it is possible to detect early on, and the first step is talking about cancer, which we are doing, because one has to be aware that there is something called cancer, and breast cancer is becoming more and more common in urban India. Self-breast exam, knowing what is normal for you, is very, very important. So if there's anything that is out of the way, that you feel is not right. So a lot of women have asymmetrical breast. One breast is larger than the other, but you need to know that is normal for you. So see a physician. So that is the first thing, that know what is normal for you. And the second thing is, we have cancer alert signs. So anything that is not getting better, there are red flags like unusual bleeding from anywhere, from any site, whether it's urine, stool, nose, sputum, or vomit, anywhere, is a big red flag. It should not be ignored. If you have weight loss, unexplained weight loss, if you have a mole or a wart which has changed size, so any lump, like Dr. Sapna said, anything that is not getting better, even if it's a simple cough or hoarseness of voice which you've suddenly developed over a short period of time, you must not ignore. So don't ignore that's an alert sign. And also there is screening that one can do. Screening is when somebody, a normal person with no problems, goes to a hospital and gets checked up. And you can have a general health checkup, but you can also have a screening checkup, and maybe we can talk about that later.
Right. There is a common understanding that, women with a family history of cancer are likely to get cancer. How much of this is true, and what are the factors that it depends on? Dr. Sapna, would you like to take that question?
So I have to say that there has been a fair amount of attention given to familial breast cancer, and some of the reasons have been, of course, when there have been certain celebrities who have had breast cancer or have had prophylactic mastectomies because they had a family history, they carried a gene which made them more prone to have breast cancer. Having said that, familial breast cancers actually do not constitute a very large number of breast cancer patients. In about 5 to 7% of all breast cancers may be familial. Now, the commonest known is the BRCA genes, the BRCA1 and 2 genes. And these are associated with a higher risk of developing breast and ovarian cancer. And there are well thought out strategies for how women who are carrying these genetic markers need to, deal with their risk reduction, fertility, completion of families before proceeding for some sort of risk reduction. Besides that, there are others, what we call hereditary breast and ovarian cancer syndromes. There are certain other genes. So again, this is something regarding which there has been a fair amount of research, and there are strategies by which, depending on the family tree, depending on the risk that is assessed amongst family members or the cancers that have already occurred amongst family members, there are genetic counselors who can advise the appropriate tests. So, though they are not a very large number of patients, about, as I said, 5 to 7% of breast cancer patients have familial breast cancers, there are strategies to address that, to deal with that.
Dr. Bhavna, what are the latest diagnostic techniques that are available for cancer screening, and how accessible are they to the women?
So there are some cancers which lend themselves to screening, and those are the cancers which you can detect at a pre-cancerous stage, or stage 0. And the 3 common cancers that we have in India are breast cancer. You detect with with mammogram, which is an X-ray of the breast, with the ductal carcinoma in situ is the pre-cancerous stage. In colon cancer, you have adenomas which can be detected by a simple stool occult blood test, and cervical cancer, which can be detected at the precancerous stage of cervical intraepithelial neoplasia. So just at the time of screening itself, you can treat that. So I think for breast cancer, if we focus on that, usually the countries with coordinated screening programs recommend screening at the age of 50. But again, new research is saying that, maybe we should start screening at the age of 45. And because the population matrix of India is younger, and we are seeing breast cancer patients compared to the West at least a decade earlier, I would say that between the age of 40 and 45, one could have a digital mammogram. So very important, patients themselves should be empowered to check in the hospital whether the hospital has a digital facility. And in younger women, do a digital mammogram with a digital breast tomosynthesis. The reason why we are doing this is because younger women have dense breasts, and dense breasts, the mammogram can actually miss certain areas. But these facilities are easily available throughout the country. But it's very important that the women themselves check that it's not one of the older machines, because the image quality is poor in that, and also the dose of radiation is higher.
I see. So how often should they screen themselves, doctor, in that case? Especially those with certain risk factors, like a family history, for example. How often would you recommend that they screen themselves for cancer?
So if the family history, usually, if we say you should start a decade before your close family member has been diagnosed. Let's say if your mother was diagnosed at the age of 50, and you carry the BRCA gene, or if there's a strong family history, then you would start at the age of 40. And in those situations, we would recommend an MRI breast. And again, one point to be made is check that wherever you're having the MRI breast, that facility has a coil. Because if you do not have the breast coil, the quality of image is poor, and again, you can miss certain areas.
Okay. So, Dr. Sapna, we all know about the latest technologies, in the treatment of cancer. So proton cancer treatment is a relatively new technology. We are hearing the term quite a lot. So can you tell us what are its applications in the treatment of breast cancer?
So let me first explain that the treatment of breast cancer has, two components. One is the local treatment, which we are addressing to the breast, and certain areas which may bear lymph nodes, such as the underarm, the area above the collarbone, and the area behind the breastbone. That is the local component of treatment, and then there is a systemic component of treatment. The systemic component of treatment addresses cancer cells that may be present elsewhere in the body, and it travels via the bloodstream. The treatment travels via the bloodstream, and it may be in the form of chemotherapy, targeted therapy, and hormone therapy. So when we talk about local therapies, if there are certain situations, for example, if somebody has undergone a mastectomy, a breast removal, and there are certain high risk factors, they need to get radiotherapy. Radiotherapy is the treatment using high energy electromagnetic radiation. And then if women have undergone breast conservation surgery, which means that the breast has not been removed, only the lump has been removed with margins, and the lymph nodes have been addressed, as I mentioned. In that case, extra treatment is required called radiation. Now, when we talk about giving radiation, we firstly we are talking about the fact that breast cancer patients are expected to live for a long time now because of good treatments being available. We know that 80 to 90% of women, ranging from, depending upon their stage, may be long-term survivors. And when we are talking about long-term survivors, we are talking about 10-year plus. So, and then we are discussing, we want them to have a good life. We don't want them to suffer the side effects of treatment. So this is where the role of proton therapy comes in. What proton therapy does is that it reduces the risk of radiation going to normal structures. So it reduces the risk of radiation going to the opposite breast, for example, and the lungs, for example. Now, in young women, one of the risks of treatment is having a second cancer. So because we are reducing the dose to the breast and the lung, we are reducing the risk of this patient having a radiation-induced breast cancer. Similarly, one of the risks associated with treating breast cancer is the risk of developing a heart problem. There are various reasons for that. Some of the drugs that we use have some impact on the heart. And then also because the heart lies just under the chest wall, it receives some dose of radiation, more on the left side rather than the right, more if we are treating lymph nodes that lie under the breastbone than not. So, and then more in diabetics, more in smokers, more in women who are obese, all the risks, all the situations where anyway the risk of having a heart problem is more. Then if you add radiation insult to that, it increases the risk of having a heart problem. With proton therapy, as compared to the other forms of radiation, the dose to the heart may be like 25%, 75% less, sometimes even 80 to 85% less as compared to other methods of radiation. And because of this, the risk of having a heart problem becomes less. So this is the role of proton therapy. You are making it better for the patient as a survivor. So when we expect her to live long, we are making the odds better for her to not have other problems.
Right. Thank you for explaining it, Dr. Sapna. Dr. Sapna did mention about the role of radiation in the treatment of cancer and how proton therapy actually helps. So I wanted to ask you, what are the general treatment modalities that are followed in the treatment of breast cancer per se? Is surgery inevitable as far as breast cancer is concerned?
So I think over the years, we have become very good at treating breast cancer and improving outcomes. By that mean 5 years, the patients living for 5 years, 10 years, 20 years. So, and the reason we have done that is we have a multidisciplinary working, where a surgeon, a radiation oncologist, a medical oncologist like I am, a radiologist, a pathologist, we all sit together and make a plan. Some patients may need surgery, radiation, chemo, targeted therapy, hormone therapy, and bisphosphonate therapy. All of these. And by doing all of these, the 5-year survival is up to 90%. So 90% are going, 90% patients are living for 5 years. So, but again, we have to individualize treatment. That's why we sit together and, make a plan for the patient. So surgery for curative treatment, I think, is a must. There is a lot of research going on right now where we are looking into whether in some cancers, whether we can avoid surgery. But surgery, I think, for curative treatment is a must. And then we individualize whether a patient needs chemotherapy or not. Not every patient needs chemotherapy. In fact, we are trying to become better at, de-escalating treatment. We're trying to make the treatment smarter and kinder so that, it does not affect a patient's quality of life much. So we can avoid chemotherapy in some patients. We do certain genomic tests, which looks deeper into the tumor, and we can avoid chemotherapy in some. So again, based on the patient's receptor status, we decide whether the patient needs hormone therapy or targeted therapy. So we have to individualize for each patient.
Right. Doctor, you did mention a lot of treatment modalities there. How important is it for women to pick the right hospital to go to, once they have symptoms, once they exhibit symptoms of cancer? And what would you think they should pick it based on?
So I think very important, this is the most important question, and I always say that, when you're buying a sari or anything, you go into 5 shops before you decide on what you want to buy. So, and this is your life. I mean, we live in a country which does not have universal health coverage, so we have to look after ourselves. So if you are in UK, it has universal health coverage, everything is streamlined, and patients, every single patient gets the minimum best treatment. Here, I think it's up to us to choose the right doctor, to choose the right hospital. So I think the first thing one should do is find a doctor who specializes in your type of cancer. Because, you have different doctors, but again, one can say in smaller cities, you may not have that luxury. So it's important that you at least find a center which has a multidisciplinary team working group. Because, sometimes if you go to a surgeon, they may want to operate, you go to a radiation, they want to give surgery. So by having an MDT working group, you have an unbiased opinion, independent opinion. And in fact, from the West, there have been a lot of studies which have shown that patients who go through an MDT, it's mandatory in UK to discuss every patient in an MDT. And at Apollo as well, every single new patient at all the 13 cancer centers in Apollo, I can say that all patients are discussed in an MDT. The treatment plan is individualized. So find the right doctor. The most important thing for me is the patient should connect with the doctor. Because, it's a relationship, it's like a marriage, it's for life. We need to hold the hand of the patient through the acute treatment, and then, after that as well, because the risk of recurrence is there for 5 years in some patients, for 10 years in some patients. So I think and also see that the hospital has the right facilities. But the topmost would be your connect with the doctor. If you're not connecting, if you feel you have doubts, your questions have not been answered, you're not satisfied, take a second opinion. There's no harm in that. It's your life. You must do that.
Correct. Dr. Sapna, a lot of people, a lot of women who undergo mastectomy often suffer from, body image issues, so is it possible that their tissues can be conserved during treatment and without impacting their, self-confidence, appearance, or, causing them anxiety at that level?
So one thing I have to mention is that for early breast cancer, uh, you know, there is very little justification to do a mastectomy now. Okay, so it is advisable for women to discuss with their doctors about breast conservation. This is not an old new treatment anymore. This is more than 3 decades old, and there is we know for sure that it is at least as good, if not more. There is some question mark about it actually being a better treatment. So that is one thing very clear, that a mastectomy is not something that we would do lightly. Even with women who have slightly more advanced disease, they can actually become eligible for what we call breast conservation, where only the lump is removed, by using some systemic treatment beforehand. So either chemotherapy and monoclonal antibodies can make women amenable to treatments which are less than a mastectomy. That is one thing. Then, of course, there is a lot of emphasis on breast reconstruction. And even in women in whom the breast has been conserved, it is possible to do what is called oncoplasty, wherein the breast tissue is moved, is reconstructed in such a manner that the contours of the breast are normal. And in women who have undergone a mastectomy, it's definitely possible. So there are certain muscle groups that are used. They are called, one is the, you can use the latissimus dorsi from the back, or you can use the muscle from the anterior abdominal wall. It can be moved, and then there are implants, so saline implants. These are all things that should definitely be discussed with saline as well as silicone, actually. These are things that have to be discussed with the doctor in case a mastectomy is being contemplated. And there is no reason in this age and time that a woman should have to suffer body image issues. In fact, the nipple can be reconstructed, a nipple can be tattooed. There are various things that can be done to make a woman feel more comfortable with the way her body looks.
Right. Thank you so much for that, Dr. Bhavna. Women, once they get cancer, they are always scared. They live in dread that, cancer will deprive them of their normal life. How have the treatment outcomes improved in the recent past, and how have they benefited the patients at large?
Like I said, the treatments have improved considerably. And earlier on, when I started training more than 2 decades ago, we would give chemotherapy to almost everyone. Now we are individualizing and selecting which patients actually would benefit and which patients would actually don't need it. Which patients need hormone therapy and don't need hormone therapy. So the side effects are also less. We are decreasing the duration of treatment as well. So the treatments have got better, and the outcomes have also got better without compromising the effectiveness of the treatment. We have de-escalated treatments, but it does affect a patient's life. So, I'll tell you about two patients, and they both have been in my patients, and one of them said, they had to put their life on hold with the diagnosis of cancer and focus on the treatment. And this is her way of, she was like, this is her way of the universe or God telling her that she needs to take time off and devote to her body. And 6 months, she will just focus on that, get through the treatment. I had another patient, she said, I will not let this beat me. I'm going to continue working. Now, this patient is a dear friend, and I have so many people like that who become friends or are colleagues as well, who have not given up a single days of work during chemotherapy. So this lady was a stockbroker, and there are a lot of other ladies I can give examples of, theater nurses, principals, teachers, who have continued to work throughout chemotherapy. We would actually schedule their treatment at 6:30, 7 a.m. They would have the treatment, drive to work, and, listen to their body, take rest and everything. And similarly, during radiotherapy, schedule their appointments so they don't miss their working day or do chemotherapy on a Friday so that they have 2 days off. So I think you can look at it both points, and I respect both viewpoints because each one of us is different. And we need to take a call as to, what our coping mechanisms are. We have got better in treating nausea and vomiting, patients admitted with infections. was very common when I was training. You know, I was just the whole time admitting patients. Now I can't think of even one patient being admitted with nausea, vomiting. It's no longer an issue. For hair loss, we have scalp cooling, you know, which helps about 50 to 60% of patients. For infections, we have injections which can boost the white cells up. So very rarely, you know, I would have a patient in a year, maybe 2 or 3, who would get admitted with side effects relating to chemotherapy.
Right, that's very heartening to know. Dr. Sapna, there's a common belief that, you know, breast cancer only affects women. Is this true?
So, you know, before I go to that question, I agree with Bhavna about that, but I just want to give the example of one lady who was one of my patients who actually used to come and get her radiation done in the lunch break and go back to the office. Her office was very close by, and she would come, get her radiation done, and go back. She was that determined to let her life be normal. So, yes, coming back to your question, so no, it is not that breast cancer is restricted only to women. Men too can have breast cancer. The ratio is about 100 to 1. So for every 100 women, one man may get breast cancer. They are treated in a similar manner. So there's surgery, there's chemotherapy as per indication, and radiation as per indication, um, and hormone therapy as per indication. The one thing that we need to be aware of is that when there is a history of male breast cancer, then we need to be sure and we need to check for BRCA gene. So, you know, there is a propensity for people who carry the BRCA gene to have male breast cancer. So that is something that we need to check for.
Right. What are some of the common misconceptions that you've heard people entertaining when it comes to breast cancer? You know, when they come to seek treatment, have you heard them say anything interesting that has intrigued you in some way? Dr. Bhavna and Dr. Sapna, I would like you both to take that question.
Please go ahead, Bhavna.
So I think the biggest misconception is, you know, like, we don't make tall claims about 100% cure rate, and but patients come to me saying that they've seen this Ayurveda practitioner or homeopathy practitioner. I mean, something which is not standard is saying that, you know, we can cure you 100% cure rate. And they have these advertisements and endorsements, dendritic cell vaccines endorsed by some societies, which is patients come with that. It's a huge misconception because it's wrong. It actually compromises their care. It breaks my heart actually when I see them 3 months later, they come with a fungating breast lump, or come with the cancer which has spread to the liver, or so a curable cancer becomes incurable because, you know, because of their belief and because of being duped into 100% cure rate. Even with stage 0 cancer, we cannot say there's a 100% cure rate, because there's a 1 to 2% chance that, you know, it can transform into cancer in the next 5 to 10 years. So, and the other misconception is, you know, whether we should isolate the patient, it's contagious, segregate, whether the toilet has to be separate because the patient is having chemotherapy or radiotherapy. So I don't think you need to do that. And the other thing is whether the first question the patients ask me is the chemo painful. You know, so again, that's another misconception, that the treatments are painful. I think, yes, post-surgery, you may have some pain, which is, you know, you get a cut in the skin, you will have pain for some time, but after that, things get better. But the treatments themselves are not painful, I would say.
Okay. Dr. Sapna, would you like to add to that?
So I would say that more than misconception, I think there's a deep-seated, you know, sort of suspicion about the whole process. And there's always this, you know, so there are these various anecdotes about, you know, X person who's being treated differently, or Y person who's being treated differently. So there is what, you know, Dr. Bhavna mentioned is that now the treatment, not just of breast cancer, but especially of breast cancer, is highly individualized. So if there are 4 women with the same 2-centimeter lump with no disease in the underarm, they may receive 4 different treatments because the tumor type is different. So there is this deep-seated, apprehension about or suspicion or a lack of understanding about how that can be so. And also, I would say that this recognition is not there, that when a treatment is advised, the treatment is advised because it's beneficial. So before, I always tell my patients, when they start off their question saying, what are the side effects of this treatment? Before that, we must dwell on the benefits of the treatment. Only then we come to the side effects of the treatment. So this, I feel this apprehension about side effects is the one that is something that really needs to be dispelled. Remembering, I'm just sort of reinforcing what Dr. Bhavna said, that when we started training, what we would do when patients were receiving chemotherapy was only keep a count of the times they had vomited. And that was it. I mean, we had a couple of drugs. They were, of doubtful efficacy, I should say, and we could only keep a count of the kind of number of times they were vomiting. While now we almost don't encounter anyone who vomits. So there has been an enormous improvement in supportive care. There are medicines which are available which bring up the blood counts of people. There are better antibiotics available in case their counts drop and they develop an infection. So I would say that there is not enough knowledge about how far the science of treating breast cancer has reached and the science of treating cancer has reached. It's actually been gratifying to see the changes that we have seen only in the last 2 to 3 decades in the treatment of breast cancer.
Right.
So one more thing, Pratibha, I would like to say is, it's very important, I think, is, so I had a patient who kept on every week, was on weekly chemotherapy, and the liver function kept on going up. So, we did a lot of tests. We checked for hepatitis, did ultrasound. Did everything. Then I stopped the chemotherapy because, chemotherapy can affect the liver function as well. That's why we monitor it. And then quietly, she comes to me and tells me that she's been taking these industrial quantities of Giloy and a lot of other things that she's been boiling and drinking. So, so I suggested she stop that, and her liver function normalized. So it's important that, discuss with your doctor, whatever you are taking, be honest and transparent with them. Because what may happen is this may end up compromising your treatment, because we will either stop it or reduce the dose, and so don't take anything which you've not discussed with your doctor.
Right.
Very right. Very right.
All right, doctor. We also speak about lifestyle changes, which have brought about a lot of diseases these days. Is breast cancer also dependent on your lifestyle? How much of lifestyle changes can lifestyle changes actually impact you having or your health in some way, so that you don't get breast cancer? Is there some way to prevent that from happening with lifestyle modifications?
Who is this for? Dr. Bhavna. Go ahead.
Dr. Bhavna, would you like to take it?
So yes, I think one of the major risk factors for breast cancer is lifestyle related, and we have enough evidence with thousands of ladies who participated in clinical trials, mainly from the West, but I think it applies to all of us as well, that if you are active, you exercise, the chances of you developing breast cancer are halved. So this is lifestyle related: exercise, excessive weight gain, use of alcohol, smoking, and these are all in your hands. Not having children, not breastfeeding. Recommendation is at least 6 months, but do it for 1 year. Use of oral contraceptive pill and hormone replacement therapy after we've attained menopause. Use of implants. It doesn't cause breast cancer, breast implant, but it causes a rare form of breast cancer called a breast lymphoma, implants which have textured surfaces. So these are lifestyle related factors which are, completely in your hand. So change them if possible. There are some factors which you cannot change, like, genetics, as Dr. Sapna talked about, being female, getting older, inheriting some genes, having a family history, Some ethnicities, are more likely, like Caucasians are more likely to develop it. Being taller, dense breasts. So these are factors you cannot change. But there are lifestyle factors you can change. Having early periods, menopause after 55. So some factors are not in your hands, but the lifestyle related factors, I think we should be mindful of them. Discuss with your gynecologist or physician. There are other pills, estrogen only pills, which you can have rather than having something which has a progesterone on it in it as well, or use it for less than 4 years of duration. So, a dialogue with your physician is very important, and being aware about that these are the things that can increase your risk of developing breast cancer.
All right, Doctor, what are the Dr. Sapna, would you like to add to that?
No, I think Bhavna's, spelled it out very nicely. I just want to mention or reinforce about obesity. Not being obese, not being overweight. I think Bhavna's spelled it out very nicely.
Right. So I wanted to ask you one question about relapse among cancer patients. So generally, what is this due to? Are there any factors that affect? That kind of impact this, relapse after cancer treatment.
So see, is that for me?
Yes, please.
So see, the reasons for relapse are actually multifactorial. And the biggest reason for relapse is the nature of the tumor itself. So there are various factors which help the doctor determine the possibility of having a relapse. And, for example, the size of the lump, the nature of the tumor, is it a more aggressive type? Has it involved lymph nodes in the underarm? And so these are some of the risks of causes of developing a relapse. So primarily the causes stem from the type of the tumor and where it is, the stage, you could say, whether the treatment has been delivered properly or not. And compliance to treatment is something that is very, very essential to reduce the risk of developing breast cancer. So, for example, after surgery and chemotherapy and radiotherapy, women are required to take hormone therapy. And we know that sometimes there can be compliance issues with hormone therapy because these treatments have to be taken for as long as 5 to 10 years. But on the other hand, we know that people who are compliant, their outcomes are better. So compliance is something very important. Then, of course, there are lifestyle changes. So exercise is known to be one of the factors that prevents the recurrence. And so what is recommended is about, 30 minutes at least. So 150 minutes or so a week of moderate exercise, or about less than 2 hours, 1.5 hours of vigorous exercise every week. These are thought to be protective. And then the other thing that is protective is maintaining your normal body weight. So not being obese or overweight. So making sure that your BMI is within what is recommended. That is another method by which one can, because that is associated with the risk of relapse.
Okay. Dr. Bhavna, would you like to add to that as well?
So just a brief thing. So breast cancer, we say hormone responsive, triple negative, and HER2 positive. These are the three main categories of breast cancer we recognize, and that's why we've become better at treating. For ER positive or estrogen receptor positive or hormone sensitive breast cancer, the risk of recurrence or relapse is there for 10 years, 15 years, 20 years as well, but it's greatest in the first 3 to 5 years. So that's why our follow-up is slightly more intensive. We see patients every 3 to 4 months, but we see them annually after 5 years. But for triple negative and HER2 positive breast cancer, yes, they are slightly, I would say, compared to ER positive, more aggressive. But the risk of relapse is greatest in the first 2 to 3 years. And they do not need to be on treatment for more than a year, actually. So I think this is the only thing which kind of helps us predict and tailor our follow-up strategy as well for our patients.
Right. Is breast cancer also seen among teenagers? Have you observed any patients, young patients coming with breast cancer?
So I think the youngest patient I have had was in Tata Hospital, who was 16 years old, and they're usually looked after by our colleagues who look after teenage and young adults. But the treatment is pretty similar. The way we classify breast cancer is similar as well, but this is very rare. I've had quite a few patients actually who are in their 20s, and just to give you the example of a young lady, and usually younger patients have triple negative breast cancer, which is aggressive. So this lady was treated for tuberculosis, for infection, kept going to the doctor, kept having biopsies which were negative. This was in London. And this went on for a year. And I've seen this in India as well. Uh, she herself said, just remove my breast. I'm so fed up of going to the doctors. And yes, she had breast cancer. So it's very important that, we do, if in a young woman, if we have doubts, take a second opinion, do an MRI of the breast, because mammogram has its advantages. It's very important to detect precancerous lesions, which we call microcalcifications, which you will not pick up on MRI. So I think sometimes when a patient is coming a lot of times with breast problems, it's important that within, I always take a second opinion from my own colleagues. So it's important that as colleagues also we take second opinions to do the best for our patient.
Right. Thank you so much for that. We've been receiving a lot of questions from our viewers who've been watching this session. So let's take a few questions right now. What is the difference between a normal cancer treatment and a proton cancer treatment? This is a question by Ms. Shahina Nizar. Would you like to take that, Dr. Bhavna?
I think Dr. Sapna should take that.
Oh, sure, please.
So basically, I think I'd already specified that in certain situations, patients require radiotherapy treatment in addition to surgery, chemotherapy, hormone therapy. These situations are if somebody has undergone a breast conserving treatment. All women who are less than 70 years definitely need to undergo radiation. More than 70 years old we need to do a risk assessment and then take a call. But definitely anyone younger than 70 who has undergone a breast conservation surgery, that means the breast has not been removed, definitely needs radiation. And then if somebody's undergone a mastectomy, then there's another sort of set of high risk features where you need to do radiation. So normal radiation is done using what are called X-rays. And these X-rays, they actually traverse through the area that has to be treated and go beyond. So when we are treating breast cancer, the X-rays travel to the normal structures that lie in that area, such as the heart, the lungs, and also to some extent the opposite breast. With proton therapy, what you do is that while what you want to treat is receiving the same dose of radiation, the dose to the opposite breast, heart, and underlying lungs, that is reduced. And that is because these are particles carrying a charge and they do not traverse beyond what you have specified as the target. So that is the role of proton therapy. It reduces the dose to the heart, lungs, and the opposite breast.
Right. Thank you so much for clarifying that. Dr. Bhavna, would you have anything to add to that?
No, I think Dr. Sapna said it very well.
All right. I have another question from Mr. Bala Subramaniam. He asked, my aunt is a kidney donor to my dad, and later she had breast cancer. Some say that it's because of her donating the kidney that she has got breast cancer. Is this true or is it a myth? And can you please clarify?
So it's completely false. It is not a risk factor. Donation of any organ will not cause any type of cancer. I think organ donation is something, again, I'm very passionate about. I think all of us should be on the organ donor list and help save lives.
Okay, thanks for clarifying that. Another question that normally is asked, as far as breast cancer is concerned, is once a woman undergoes treatment, or if she's still under treatment and if she's pregnant, can she still give birth to the baby?
Yes, absolutely. I mean, so there are guidelines. I was part of one of the Royal College guidelines as well. Breast cancer during pregnancy should not compromise treatment for the patient or for the child. So yes, in first trimester, first 12 weeks, there are certain drugs which we cannot do. We can still consider surgery under local anesthesia if it's needed. In second and third trimester, I mean, I have myself given chemotherapy to patients, and we have actually taken the baby to term. And there are a lot of studies, and in fact, there was one study with an 18-year follow-up and looked at, same matched controls in the population, whether the child was affected as far as their cognition, intelligence, physical well-being, emotional well-being was affected. So it was not affected at all. So ladies can carry the child to term. Cancer should not be an indication for termination at all.
Right. Interesting. Dr. Sapna, would you like to add something to it?
Yeah, as Bhavna said, the only precaution is that we don't do radiation during pregnancy. So the treatment is tailor made in such a way that everything else can happen. You can choose a surgical technique which may not involve radiation, or you may do radiation after the baby's been born. This is the way to handle it. There are some thoughts about whether in certain situations one may administer radiation safely, but it's not something that is advisable when the fetus is in utero. So, but the chemotherapy and surgery can be tailor made to the stage of the pregnancy, whether it's the first trimester, the second, or the third.
Okay. Doctor, I have another question from Mr. Vaibhav. He asked, with breast cancer having become very common these days, the healthcare costs have been on the surge every year. Approximately what kind of costs should one be prepared for to undergo quality treatment once diagnosed? Should special cancer care, special health insurance policies be a priority for women going forward? Dr. Bhavna, Dr. Sapna, would you like to take that first then?
So actually, it's very difficult to sort of give a prediction of the cost of treatment that may be involved, because largely the cost of treatment depends on the type of tumor. So as Dr. Bhavna mentioned, there are various kinds of tumors. There may be, specifically, I want to say that there is one particular tumor called the HER2 positive tumor, wherein the cost of treatment may be substantially more than in other situations. However, if we keep this aside, I think there's a certain amount of predictability. Also, of course, there is the issue of where one is choosing to get treated. So, of course, in India, we know that we have a wide spectrum of health facilities available, and the costs vary as per that. And in normal circumstances, if we are not considering this specific group, which is the HER2 positive disease, and when we are talking about primary treatment, then I would say that insurance policy of about 6 to 7 lakhs would approximately cover everything. And yes, so cancer specific insurance is not a bad idea. Not just for breast cancer, but from the point of view of other cancers too. Yeah.
Right. Dr. Bhavna, you would like to add to that?
So yes, I would. Basically, I think, like I said, we don't have universal health coverage, but the Indian government is doing fantastic work. You have Ayushman Bharat, which has something they did in April last year was they decreased the cost of, I think, more than 30 drugs, so that it was affordable to patients. I think there are a lot of things being done. There are patient assistance programs for expensive drugs that if you buy two, one. So there's something. So a lot of companies are doing that as well. The government is doing a lot of work, and I think more needs to be done. Yes, to reach out to everybody. But I think it's a fantastic start in decreasing the cost of cancer care. The one example I would like to give is when I was working in Bangalore. So we had about 60% patients of our were from below poverty line. And as per the scheme, I had to deliver the breast cancer chemotherapy in, I think, 2,000 rupees, 2,500. And one of the anti-nausea drugs itself can cost 1,000 rupees. So it was very difficult for me to try and do it. So what we did was we replaced that with ginger syrup. And again, a lot of studies have been done on that. And I don't think I had any patient who had vomiting, and we were able to deliver that in 2,000 rupees, the breast cancer chemotherapy, and complete 4 cycles in about 10,000. So I think we have to we have to think laterally, and it is possible to deliver care to everyone in a cost-effective manner here. And the West needs to learn from us, because even they are resource limited.
I'd like to mention here about the fact that we in India have access to, generic medicines. I think we are providers actually to a large part of the world, especially to the developing world. And that, I think, is a boon. I mean, it's a controversial subject, but from the point of view of, being a rich country or countries, I would say that's actually something that's really very good.
So I think I would just clarify, it's no longer a controversy. Biosimilars, I mean, I was in the NHS and we were using biosimilars in UK in the NHS. So I think the whole world is using it.
I meant the controversy is more about, you could say about, in certain, I came across the fact that about intellectual property issues. I would say there's no controversy about efficacy, but I think more about intellectual property.
Right. Moving on to the other questions. I have a question from Ms. Priyampada Sundar. It's been a common habit for a lot of decades for relapse patients to be skeptical about modern medicine and try to undergo Ayush treatments. What are the challenges faced by an healthcare provider due to, people seeking other methods of other treatment, alternate medicines? Probably?
So I think once you've finished your standard treatment, whether it is chemo, radiation, surgery, once you've finished all of that, and you want to try some complementary, there are some complementary therapies which I recommend, for hot flushes. There is evidence for using acupressure, acupuncture. So these are complementary therapy, using aromatherapy, using reflexology. So all of these are fine, along with the treatments as well that are going on. But alternative medicine, I think once you've finished your treatment, if you want to do something for your health, for Ayurveda, I think that's absolutely fine. And I think we should encourage the Ministry of Ayush to do trials which are peer-reviewed and published, so that, the rest of the world learns from them as well.
Dr. Sapna, would you like to add to that?
Yeah, so I think one of the issues that we face with people who have taken alternative treatments is this very fact that, their evidence is anecdotal, which means that there may be the odd case here who may have responded or not, and that's what makes patients go in that direction. However, it has not been scientifically studied so far. So there are misconceptions that, because these are herbal treatments, they are safer or effective. What is not understood often is that, for example, there are so many chemotherapy medicines which are plant derived. So it's not about the issue of herbal and otherwise, but it's about the process of study. So there is a standardized method to administer, and then a standardized method to assess the response. And that is what is, that process is very rigorous in allopathy. And so if there are effective medicines in another school of medicine, if they pass through this stringent set of tests, they would be accepted. So I don't think allopathy, or what is called the Western School of Medicine, is more about the rigor of the process of testing rather than the issue of the medicine itself. So I agree that what we need to really do is put these so-called alternative medicine schools of medicine through the same rigorous process, and it would be beneficial for patients if they meet that standard.
Doctor, there's a question from Priya. She asks, is it true that cancer skips a generation?
No, I don't. Sorry.
Go ahead, Sapna. Sorry.
No,
Yes.
I don't think there's any such, that it skips a generation. There is no such, but yes, cancer can occur in families, and so that you can carry a genetic risk, and that genetic risk may not have the same penetrance in every person or in every generation, but there is no such dictum that it skips a generation.
Okay, Dr. Bhavna, sorry, you wanted to add to that?
No, it's fine. That's what I wanted to say.
Okay. There's no evidence to prove that it skips a generation, is what you say. All right. Another question is from Ritu Vijay. She asks, how does menstrual and reproductive history affect breast cancer risk?
So I think being exposed for a long time to hormones is a risk factor, but this is a risk factor which we can do nothing about. So having early periods, early menarche or late menopause, menopause after the age of 55 does increase the risk of breast cancer, but there is nothing we can do about it. One thing you can do is from the age of 50 onwards, start having a screening mammogram at annual intervals or at least 2 yearly intervals, 1 to 2 yearly.
Okay. Dr. Sapna, you wanted to add to that?
No, that's fine. That's fine.
There's a question from Vaibhav again. Given the advancements in the technology and healthcare facilities today, can someone with stage 3 or stage 4 cancer be treated with and lead a healthy life ahead?
Very much so, very much so. So let me specify, when we are talking about stage 3 cancer, we are talking about loco-regionally advanced disease, and we are talking about long-term, we are talking about treatment with curative intent. When we are talking about stage 4 disease, I would say that we would divide this into two. One would be a patient who has locally advanced disease, again, where with certain, tailor making of treatment, we are still talking about treatment with curative intent. And when we are talking about the other form of stage 4 disease, which is disease which has spread elsewhere in the body, there you could sort of differentiate into two. People who have what are called oligometastatic disease, which oligo means few. So in patients in whom the cancer has spread to few places, they have a different outcome of treatment versus somebody in whom the cancer has spread to multiple places. So I let Dr. Bhavna talk about, what happens when multiple places are involved, but I'll just tell you a little bit about oligometastatic disease. Oligometastatic disease, as I mentioned, is when cancer is spread to, say, for example, less than 5 sites. Then we go all out, treat all these 5 sites as well as the breast cancer with aggressive intent. Patients can still lead a normal life, but I would say that I think we would be guarded about talking about their long-term outlook. But for every other site below that, that means stage 1, stage 2, stage 3, definitely, and certain types of stage 4, the intent of treatment is definitely curative.
Okay, Dr. Bhavna, you wanted to add to that?
So I think as we are getting better at treating patients, patients are living longer with whether it's stage 3 or stage 4. Even with stage 4, we have patients who are 10 years later, 15 years later, either off treatment or on treatment, doing amazingly well. So that's why this branch called cancer survivorship has come up, which looks at at different aspects of their health, for prevention of recurrences, to surveillance of late toxicities or late side effects that the treatments may cause, psychological health, bone health, sexual health, to look for second cancers which may develop 10 years, 15 years later, to look at their genitourinary health. Some patients have chronic fatigue. So all of these are addressed as part of, what we have after completion of therapy clinic at Apollo. And again, this is cancer survivorship is something which I'm quite passionate about, because it is very important that, patients have a normal quality of life. And all of these, including looking after hot flushes, vaginal dryness, bone health, all of these are very important for a lady's quality of life.
Right, doctor, we often speak about, post-treatment outcomes, as to how do they lead a very normal life after the treatment gets over. So what are the factors that this depends on? Follow-ups is one thing. What other factors can you think of, which will impact a patient's long-time health?
So I think long-term quality of life is very, very, the whole aim of treatment is for two things, patients to live longer, and living longer is not enough. It's having a good quality of life as well. That's important. So like you said, monitoring for recurrences is the most important. Second thing is, the physical well-being, whether the sleep is good, whether they need any help with fertility issues, younger women want to have children maybe 2 years after treatment, to helping them in their journey, psychological well-being to help them control anxiety, depression. Fear of recurrence is the most common factor that causes anxiety and depression. The other thing is social well-being as well, how it is affecting their relationships, the appearance, the body image that you talked about. Financial toxicity is quite important. I think in India, we cannot ignore that. We have to address that right at the beginning when the patient comes. And we have to tailor our treatments. If a drug is giving you a benefit which is 2% and is costing so much that you have to mortgage your house and take loans, I don't think we should recommend that, or we should talk about it. And so all of these things, the complexities come in right at the beginning when the patient comes in, but it helps them with their longer quality of life. And also the spiritual well-being, I think inner strength, all of these are very important aspects of quality of life that we need to address with the patients.
Dr. Sapna, would you like to add something to that?
So there are just two things I want to add to that. One is that, as Dr. Bhavna mentioned, the process of preparing for the future starts, right from the beginning. So, for example, one of the things that we pay attention to after surgery is shoulder mobility. I mean, just that, being able to do your or starting your exercises early after surgery has a long term implication, because if you don't, and if attention has not been paid, if the patient hasn't learned those exercises, hasn't been taught, or has not been been able to do them, uh, a simple thing like not being able to mobilize your shoulder properly can actually have enormous long term impact. And the other thing, of course, Dr. Bhavna specified so nicely about all the various aspects. But I would say that, and one thing that I want to add to that is that, whenever there's a diagnosis of cancer, it really makes you confront a lot of issues, a lot of, so it's sort of like a very intense experience, not just from the treatment point of view. So it kind of brings things into focus. And I think it's also very important at that point of time for friends and family to rally around the patient, and for us to also be cognizant of the impact of this treatment on the caregivers. So on the spouse, on the children. I think it's a very emotionally difficult time also for them. In our country, in our culture, we tend to take this for granted. But personally, that's very close to my heart. I feel that caregivers also require a lot of emotional support during that time. And that is something that must be sort of specified, stressed.
Very interesting point there. Doctors, with that, we've come to the end of this session almost. But before I let you go, I wanted to pose one final question to each of you. So, Dr. Sapna, I wanted to ask you what can be done to prevent breast cancer? Because today we're talking about awareness about breast cancer. We're talking about debunking myths about breast cancer. What can be done to prevent breast cancer? And what would your advice be to young women who are watching this webinar today?
So I would say what is considered a generally healthy lifestyle, being active, having a lot of sort of vegetarian food or food which is rich in green leafy colored vegetables and fruits, being active, having alcohol in moderation, avoiding smoking, being aware about screening, and being aware about your body and paying attention to symptoms that you may have noticed, and definitely being aware of how to do a self-breast examination. So in the West, there is a question mark about whether self-breast examination is useful or not, but I would say that in our country, it's very important that women know, and you can just go to the internet and learn how to do a breast examination. Make it a part of your routine. If you're if you're still having your periods, then about 3 to 4 days after your periods get over, that's when the breasts are the most supple and the most amenable to examination. And you must learn how to do a self-breast examination. If you've attained menopause, fix one particular day of the month, the 1st or the 15th, something that you won't forget, and remember to do a breast examination once every month.
Great. Dr. Bhavna, you have anything to add to that too?
So yeah, just to add to that, I would say that be proactive about your health. There are some things that you can do immediately. If you have women or young girls, whether it's your maid's daughter or your daughter or your granddaughter, make sure they are vaccinated against the human papilloma virus, the cervical cancer vaccine, which prevents 80% of cervical cancers. It's so easy to do. It's in your hand. Make sure they are part of the national immunization program for hepatitis B vaccination, which prevents liver cancer. Breast cancer and colon cancer is rising in Indian metros. Very simple, do a breast exam if you're young. If you have doubts, go and discuss. Have a simple x-ray of the breast. And for colon cancer, you can have a stool occult blood test, which is a simple stool test, but make sure it is done by the fecal immunochemical method, because the older methods, you need to give 6 stool samples. So these are things, which you can start doing right from today.
Right. Thank you for that, Doctor. One more question I have before we completely wrap up the session. What is the role of family support in bettering the treatment outcomes and improving the quality of life of cancer patients?
So I think it's very, very important. And there are a lot of studies actually which have been done which show that the breast cancer patients with a higher family support have less depression and anxiety symptoms, and breast cancer ladies who have their spouses support have also, and empathy and support, actually are more compliant to the treatment and have less depression and anxiety. So I think family support is very, very important, but it's also very important that the family looks after their health as well.
Right. Dr. Sapna, you have anything to add to that?
Yeah, I would agree that, right from the nitty gritty, doing the blood tests and et cetera, looking after the diet, and of course, then hand holding. There are people, even in developed countries, who are not able to undergo radiation because there's nobody in the family who can drive them to the radiation center. So these are practical issues. So definitely, friends and family both contribute a lot to make this make it better for the patient, both from the point of view of the emotional support as well as simple logistical issues.
Right. Thank you so much for that, Dr. Bhawna Sirohi, Dr. Sapna Nangia, for joining us for this very informative and very, very interesting session about breast cancer. We did manage to debunk some of the myths, I presume. And thank you so much for joining us. And last month, in fact, Pink October was supposed to be the Breast Cancer Awareness Month. We are taking it a little later, but we have taken questions from the audiences too. So thank you so much for answering them very patiently. We are all going back a little wiser, I'm guessing. So thank you so much, and we hope to join. So please do stay tuned to the other sessions that are coming up in the afternoons. Thank you so much for joining us.
Pratibha, thank you very much for making this so interesting. And, it was so wide ranging, the discussion. Your questions had so much insight. So thank you so much for that.
Thank you. Thank you. Thank you, Dr. Satya.